Today we're going to talk about pediatric cardiac considerations, and we're going to focus on our pediatric dysfunctions, our pediatric congenital heart defects, and our pediatric heart diseases that we see often in this population. When you think about dysfunction, dysfunction means not working properly. So if we think about the heart, what are some potential side effects if our heart is not functioning properly? So before we really get into dysfunction, we have to recall what the heart does and how it works. So we're going to get into the circulation of blood through the heart, why the heart works like it does, and then we can focus more on our dysfunction of the heart. So we're first going to look at the circulation of blood that moves through the heart of a fetus versus circulation of blood that moves through the heart of a newborn, because those differences are really important when we think about why the heart can have dysfunction and why the heart might have defects. So remembering this circulation from fetus to newborn is super important as you move through this lecture. So remember that when we're looking at a fetus heart, the blood bypasses the lungs. So we are not breathing oxygen and we are not having the same pressure changes as we do in a patient who is breathing oxygen like a newborn. So when you look at the fetus heart, that heart has certain structures in place that help the heart function and move blood throughout the heart and circulate throughout the heart without having to have the oxygenation that a normal heart has. So those structures that we have in place in utero are called the foramen ovale, the ductus arteriosus, and the ductus venosus. And so when you look at the picture that we have in front of us, the foramen ovale is this little connection between the two atria. We also have the ductus arteriosus, that is a connection between the pulmonary artery and the aorta. And then we also have the ductus venosus, which connects the liver and the inferior vena cava. And we have these structures in place to allow blood to circulate through the right and left side of the heart, because we're not using the lungs as that kind of middleman like we do in the heart that breathes oxygen. Now, when we have a normal heart outside of the uterus, we have these structures turn into ligaments. So there is no connection anymore. This is a little ligament now that used to be the ductus arteriosus. You can't see it between the two atria, but there's a ligament that exists here that does not allow the atria to connect anymore. And then same thing down here with the ductus venosus, a ligament forms, and therefore there is no connection between the liver and the inferior vena cava. It is very important that these ligaments form. If they don't, once the baby is born, then the blood connection still exists, and then we end up with something like a congenital heart defect. And that's a major problem because we know that these connections should not exist normally. And so that means blood is not flowing normally through the heart. So when we have a patient who is in utero, they again have these structures in place that exist to allow blood to flow through the heart without breathing oxygen. But then once the baby is born and the umbilical cord is clamped, we take our first breath of air. And when we take that first breath of air, our lungs expand, our oxygenation increases, and we have pressure changes in the body. The pulmonary pressure decreases while our systemic pressure increases, which then causes these structures to close and then turn into our ligaments. So this is why it's so important that the baby get their first good breath so that we can have these structure changes happen due to the pressure changes in the body. Now, one thing to note, the ductus venosus that connects the liver and the inferior vena cava, sometimes it can take up to a week to close. So we know that when we have abnormal structures in the heart, because those abnormal structures allow a different connection and allow blood to flow differently, we can have different sounds. And with different sounds, when we're listening to that heart, basically we hear that different sound as a heart murmur. And so it's very common in newborns to hear a heart murmur for the first couple of days up to a week, waiting for that ductus venosus to close. If we hear a heart murmur, we're still going to investigate it. But if we hear that heart murmur and we do an echocardiogram and we see that the heart looks normal, then we're not going to be as nervous about a potential defect or some other kind of problem with the heart, because we know that ductus venosus can take up to a week to close. So when we have our patient who is now breathing oxygen, we should have normal flow of blood through the heart. So just like an adult patient, the blood should move in the same fashion in a pediatric patient, because we are breathing oxygen now, okay? So remembering your blood flow through the heart is going to be key for you as you move through this lecture and move through this content. So I would make sure you know this information like the back of your hand, because knowing the normal flow of blood through a normal heart is going to be key to understand congenital heart defects and how they work. So remember, we have blood that flows up into the superior and the inferior vena cava, down into the right atrium, through the tricuspid valve, down into the right ventricle, into the pulmonary artery, and gets into the lungs. And then we go through the pulmonary vein, and then we come down into the left atrium, down through the bicuspid or mitral valve, down to the left ventricle, into the aorta, and then out into the body. Now, a few things I want to make sure you know. So these two little vessels over here on the side that I'm indicating with the highlighter are part of the aortic system. And these two vessels move blood from the left ventricle into the lower parts of the body. Okay, so that means like the lower legs, the lower abdomen, and then these upper vessels of the aorta push blood into the upper part of the body. So like the chest, the head, the brain. That's going to be really important as we go through the lecture and talk about specific congenital heart defects. Also, I want to make sure that you guys know a little bit about the heart. So if you think about the heart, what is the biggest chamber of the heart? And that is your left ventricle. Also, the left ventricle is the highest pressure chamber in the heart. The highest pressure vessel is the aorta. And this both makes sense because the aorta's job is a really high pressure. Its job is to push blood all the way through the body, down to the bottom of the toes, all the way to the tippy top of our head. And all of that is coming from the left ventricle. The left ventricle has to use a lot of muscle and force to push the blood up into the aorta, and the aorta has to work to push it to the rest of the body. So the aorta is the highest pressure vessel, and the left ventricle is the highest pressure chamber. The other thing I want to make sure you guys remember back from like biology is how fluid moves. So remember that fluid moves from an area of high pressure to an area of low pressure. So if I have a really high pressure left ventricle, that's going to be important when we think about specific types of congenital heart defects. And I'll leave that there for now, and I promise we'll get back to it when we start talking about our defects. So before we get into the nitty-gritty of all of our defects, there's a few things that I want to kind of set the table with first. So first, when we're thinking about our heart is really important to our oxygenation and really important to our perfusion. If we have a decrease in perfusion, this can be related to our heart not functioning correctly. And if our heart is not functioning correctly, it's not going to be able to pump blood effectively, which means we're going to have poor perfusion signs. So if I know my heart is having dysfunction, it's not functioning properly, then I'm going to have poor perfusion. What does that look like when I do my assessment? What does a patient who has poor perfusion look like? That's going to look like increased cap refill, decreased skin turgor, changes in vital signs, maybe pale skin, maybe cool skin, maybe fatigue. So remembering what a poor perfusion patient looks like. If we're not having appropriate function of our heart to perfuse blood and red blood cells, which carry our oxygen, then we're not going to be oxygenating appropriately. What does an improper oxygenating patient look like? If we're not oxygenating well, we're going to have changes in vital signs. We might be showing signs of respiratory distress. We might have low O2 sats. We might have blue tint to our skin or to our lips or to our nails. So if our heart is dysfunctioned for whatever reason, we can have major effects in our oxygenation ability and our perfusion ability. Now, if you think about expected findings that we see in a pediatric patient in terms of our vital signs like our blood pressure and our heart rate, what do we normally expect to see? So it's really important that we know our normal so that we can identify when a patient is not normal. That's a significant flag that tells us the patient is abnormal. So if I expect my pediatric patient to normally have a higher heart rate, when I see a low heart rate, I'm concerned. If I normally see a pediatric patient and expect that patient to have a blood pressure of X, and I see a lower blood pressure of Y, then I'm going to have a red flag of concern. So remember, when we're thinking about our pediatric patients compared to our adult patients normally do have a higher heart rate and a lower blood pressure. Why is that? So we have a higher heart rate because our heart is very efficient and moves blood very quickly. And because we are moving blood very quickly because we have a smaller surface area to work through. Versus an adult, the heart has to work harder to push blood all the way through a larger surface area, and the return of blood back to the heart is slower. So that's why we typically see a higher heart rate in our pediatric patients, and that's why over time it starts to get lower as we get bigger. For our blood pressure, we typically have a lower blood pressure in our young pediatric patients, and that gets higher over time as we grow bigger. And that's because the heart doesn't have to work as hard to pump blood through a smaller body surface area and a body that doesn't really have any comorbidities, versus an adult patient whose heart has to work harder to push blood all the way through a large surface area and potentially work through comorbidities. So when you think about heart rate and different areas of pulses, so if we think about a brachial pulse, a radial pulse, a femoral pulse, a popliteal pulse, a pedal pulse, they all should be pretty the same for a pediatric patient because there's not a lot of difference between the upper and the lower because they're really small to begin with. There's not a lot of difference or change between the head and the feet. Whereas in the adult patient, we might see a little bit of a difference between the radial pulse and a pedal pulse. And it could be related to their perfusion ability, it could be related to their heart function, and it could also be just related to their size. But for the pediatric patient, we don't expect those differences. Same thing with blood pressure. If you take a blood pressure in the arm of the adult patient and the leg of the adult patient, they're going to have differences in their blood pressures. Usually the pressure in the legs are going to be higher than in the arm of the adult patient. Because think about it, the heart is working through gravity, working through body surface area, having to pump down to that lower area, which is why our pressure is going to be higher in our legs than our arms. In the pediatric patient, again, we have a smaller surface area that we're working with. So we expect our blood pressure in our arms and legs to be pretty much the same. And this is really important to understand this foundation of knowledge before we get into the nitty-gritty of our cardiac defects. So just remind yourself about the differences between pediatric and adult patients when it comes to our assessment findings and our vital signs, and remember what a patient might look like if they have poor perfusion and poor oxygenation. And think about, from a heart perspective, why they might have those poor perfusion and poor oxygenation difficulties. And it might be because their heart is not functioning appropriately and not pumping effectively. As we continue to build on our foundation of knowledge about our cardiac system, I do want to talk about murmurs. So when you think about murmurs, what comes to your head right away? So right away I think, okay, a murmur is a weird sound that I'm hearing with a stethoscope when I listen to a heart. But why do we have a murmur to begin with? So a murmur is typically related to a couple of things. It can be because of an anatomical issue. So there's a weird connection that shouldn't be there. Just like we said earlier, when the ductus venosus takes a little bit longer to close, it's an abnormal connection, so blood is flowing differently, so I'm going to have that weird sound. Another reason why we might have a murmur is because there's a change in the blood flow, and the blood flow specifically is very turbulent. So when we have very turbulent blood flow, that causes a whoosh sound, and that whooshing sound makes us hear that sound between the lub-dub sounds of the heart, or wherever that murmur is occurring in the heart cycle, either diastole or systole. So when we hear a murmur, it's really just either an abnormal connection or turbulent blood flow. So ultimately, a murmur is a secondary problem. There's an underlying reason why we have a murmur. Okay? So this is something that we really have to remember to educate our families and our patients about. Because when family members hear murmur, they think, oh my gosh, my child needs, a heart transplant. Something's wrong with their heart. Which very likely they might have something wrong with their heart. But there also can be other reasons why we have things like turbulent blood flow. And we're going to get into that a little bit. So when we think about murmurs, there are three main types of murmurs, which we'll get into. And murmurs are graded on a system, a numerical system. They're graded from 1 to 6. 1 being very, very minimal, you can barely hear it with a stethoscope, and 6 being where you can almost hear it without the stethoscope being on the patient. So grade 1 is very light murmur, grade 6 is an extreme murmur. Usually a grade 1 or grade 2 murmur, for the most part, are going to be pretty benign or not worrisome. A grade 4, 5, and 6 are going to be something significant and something very worrisome. We also classify murmurs based on where they occur in the cardiac cycle. So are they occurring before diastole, after diastole, or after systole? And so it's really important when you hear a murmur to make sure that if you're new at listening to murmurs, you get somebody who's experienced to listen to the murmur with you to confirm that, yeah, it is a murmur, and to confirm, what grade it is and where it is in the cardiac cycle, and where you're hearing it on the chest. Remember the different parts of the chest that we listen to: the aortic, the pulmonic, the Erb's point, and the mitral area. And so where you hear it at on those spots in the chest can also be significant as to where the murmur is occurring in the heart. But those are kind of more advanced skills. You just need to know these basic pieces of what we have on the slide here. The biggest concern that we would have if we assess the patient and we hear a murmur, what we want to make sure we assess for, is this a new onset murmur? If it's a new onset murmur, that's a red flag that something's not quite right. Or if the murmur has changed, if it is a chronic murmur, they've had it for a long time, and now it's got a change to it, that would be a red flag. And if we have a red flag murmur, so we have something new onset or something that's different than it used to be, then we really have to worry about a potential for cardiac dysfunction. Is there something causing the heart to not function properly as to why we're hearing this murmur? Is there some type of abnormal connection, or is there some reason why we're having this turbulent blood flow? And again, if our heart is not functioning correctly, we can have oxygenation and perfusion issues. We can also become at risk for infection in certain situations. We can also have growth and development issues in certain situations. And we'll get into those specifics as we move on through the content. So there's 3 different types of murmurs. There's the innocent murmur, where there's really no known reason why it happens. It just happens. And when you look at an EKG and when you look at the echocardiogram, everything's normal. So these are very benign, and we don't worry about them. We just listen every time we assess our patient and make sure there's no change. There's also functional murmurs, and functional murmurs are also benign murmurs. They are just a red flag to tell you something is wrong. So usually when we have a functional murmur, it's related to 3 main things. 1, anemia, 2, fever, or 3, rapid growth spurts. So if you think about what we talked about earlier, murmur is usually related to turbulent blood flow. Why does blood flow become turbulent? Well, it becomes turbulent because of pressure or because of thin blood. So in the case of fever, we have pressure changes because our metabolism is hotter, our body is working harder, and so our pressure in our body and our pressure in our heart and in our blood being pumped is moving faster. And so that pressure change causes a change in the way the flow of blood is happening, or creating turbulence, and that's why we get the sound of a murmur. Think about it like if you're turning on the shower and you start really slowly, it's going to just trickle. But then when you turn it up and you increase that pressure, you're flowing a lot faster, a lot more turbulent, and the sound is a lot louder. With anemia, we have turbulent blood flow because of the concentration of blood is very diluted. So if you think about anemic blood, we don't have all of the parts that we normally have in our blood. We don't have as many red blood cells. So I always compare anemia blood to coffee versus normal blood, which is like a smoothie. So when you pour a smoothie on the floor, which I don't know why you do that, but if you did, if you pour a smoothie on the floor, it's going to kind of glop, glop, glop. Whereas if you pour coffee on the floor, it's going to splatter. And so the coffee, since it's thinner, is going to have much more turbulence, much more sound versus your smoothie. So same kind of deal here. When we have anemia, our blood is moving a lot faster and harder through our heart, which is why we have that murmur sound. With rapid growth, it's similar to anemia. We have all the parts, but because we are growing so rapidly, our blood volume can't keep up. And so there's a lot of higher pressure trying to pump that blood faster through our heart, creating that turbulent sound or that murmur sound. So with these functional murmurs, if we fix the problem, the functional murmur should go away. So what do we do for anemia patients? We give them blood. And if we give them blood and return their hemoglobin back to normal, then that means their murmur should go away. If we correct a fever, the murmur should go away. If we allow blood volume over the course of a few months to catch up with rapid growth spurts, then a murmur should go away. If we fix the underlying issue and the murmur still doesn't go away, then that is a red flag that maybe we've missed something and something else is wrong. So the other type of murmur is an organic murmur. And an organic murmur is a more significant type of murmur telling us that there's something wrong with the anatomical structure of the heart. So that means that there's some kind of abnormal connection that's allowing blood to flow differently, which is why we're getting that heart sound or that murmur sound. Now, organic murmurs, we do need to do something about. Yes, there's an underlying abnormality, so how do we fix that abnormal connection or that defect so that we can get rid of the murmur and also get rid of the cardiac dysfunction that we would sustain because of this anatomic abnormality. So when the heart is not functioning correctly, or we're in dysfunction, our myocardial or our heart muscle is not working properly. So when you imagine the heart muscle not pumping effectively and appropriately, what are you going to see on your patient? Remember, that's going to be a direct reflection of perfusion ability and oxygenation ability. So we've already talked about what that patient might look like. So when our heart is not working properly, we can see those perfusion signs, those oxygenation signs, and we also start to see our heart working harder, because the more we're not perfusing, the more we're not oxygenating, our heart is going to continue to compensate and work harder and harder and harder. And as it works harder, we're going to see those effects in our patients. So we normally do not expect to see something like diaphoresis or sweating in our infants. But if they have a congenital heart problem and their heart is not functioning properly and it's compensating for that dysfunction, we're going to start to see a ramp up in their body working in overdrive, which would be symptomized by things like sweat, things like increased work of breathing. And with increased work of breathing, we can end up in potentially respiratory distress because we're working harder and harder to oxygenate. We can also hear our heart murmurs like we talked about if we have a dysfunction related to a defect problem or an abnormal connection problem. We might have extra heart sounds if we have an abnormal connection with our anatomy of our heart, or we can have extra heart sounds if we have too much fluid on our heart. So if we think about this for a second, if our heart is working in overdrive, so if you imagine our heart as a rubber band, okay? So our heart is pumping and we're working really hard and we're building that muscle. Over time, that muscle is going to get bigger and bigger and bigger, right? But as that muscle gets bigger and bigger and bigger, we're stretching those muscle fibers. So if you think about a rubber band, when you have it nice and normal size is nice and tight. But as you stretch it, stretch it, stretch it, it gets looser. And so as our heart muscle fiber gets looser, it makes our muscles not work as efficiently as it normally would have. And so if our heart pump, if our muscle is not pumping as efficiently as it used to, that means we're going to potentially have fluid backing up. And so if we have fluid backing up, we can end up in things like congestive heart failure. And yes, pediatric patients can have congestive heart failure. And so if we have extra fluid on the heart and in the body, we can have extra heart sounds. And those are usually termed S3 and S4. So we know when we hear S1 and S2, that's our lub dub. But sometimes with extra fluid on the heart, we can hear an S3 and S4. Also, if our heart is pumping harder and harder and harder and getting bigger and bigger and bigger, it's going to make the heart get bigger. And so then we see things like cardiomegaly, which can be seen on things like a chest x-ray. If our heart is not working properly and we have a backup of fluid and it's really compensating and working extra hard and not able to function correctly, we can end up with different types of shock. And one of those shocks is cardiogenic shock. And we never want to get to a place where we're in cardiogenic shock. That means we have missed the opportunity to try to make the heart function appropriately before then. So if you think about how do we help the heart pump more effectively, we give things like digoxin to help improve the pump and help improve the efficiency of that pumping blood to our body. All right, so now we're going to start getting into our defects. And I just want to remind you guys, before you dive into this section of the lecture, really make sure you've understood the previous slides, because if you don't understand the previous information, you're going to really struggle with the next set of content. So the heart defects that we're going to focus on for this course are going to be specifically cardiac defects that a patient is born with. There are other types of defects. There are other types of electrical defects we're not going to necessarily get into electrical problems in this course. We're going to get more into the congenital defects that patients are born with and their anatomical defects. So that means there's something anatomically wrong with the heart. You will get into electrical problems of the heart when you get into med-surg too. So congenital heart defects are not very common. Usually they occur in less than 1% of babies born. But if those babies are born with a congenital heart defect, they are very high risk for not being able to survive past their first birthday. It is a leading cause of death in those population-specific patients who have been born with congenital heart defects. Usually the patients who are born with congenital heart defects, a lot of them also have other comorbidities. So a lot of times, if they have one defect, they will have another defect. Or of those children that have a defect, a lot of times they will have a genetic abnormality as well. So we usually see a lot of Down syndrome babies, about 30 to 50% of Down syndrome babies will be born with a congenital heart defect. But that's not to say that normal, healthy children who do not have genetic defects can't also be born with a congenital heart defect. I actually have two friends that one I went to high school with and one I went to nursing school with. Both of their children are completely normal in terms of genetics, but they were both born with congenital heart defects, and they are doing very well. So the ability to survive is really about the type of defect that the patient is born with, and it's also about the ability of that patient and family to receive top quality medical care and be able to return often to receive medical care in terms of follow-up and understanding the medical treatment and plan of care for that patient at home. I also want to note that the most common congenital heart defect is something called VSD. And if you want to write out what this is, VSD is ventricular septal defect. And ventricular septal defect is, again, the most common type of congenital heart defect. And the congenital heart defects are named so appropriately. They're named so much easier than our pharmacology drugs, because the pharmacology drugs are named like these super long names that you can't pronounce and make no sense. But the congenital heart defects are named to specifically target where the problem is. And I'll get into more detail about that and show you what VSD really means here in a little bit. So again, we're going to have a little bit of foundational knowledge here before we get into our specific defects. So remember, when we have a defect, we know the heart is going to be in dysfunction. It's not going to be functioning properly. And if our heart is not functioning properly, we're going to have problems with perfusion, and we're going to have problems with oxygenation. It doesn't matter what type of defect it is. As long as we know there's an anatomical defect, we know it's going to have a dysfunction, and we know that dysfunction is going to lead to poor perfusion and poor oxygenation. On top of all that, most likely every defect that we encounter, we're going to have fluid volume access problems because, like I said earlier, we're going to have the heart compensating, and over time, those muscle fibers are stretching. Over time, our heart is not going to be able to pump effectively, so we're going to have fluid buildup and backup. If we're having fluid buildup and backup, we're going to have acid-base imbalances. If we're holding on to lots of fluid and we're fatigued and we're not perfusing well, we're going to have nutrition problems. We're going to have growth and development problems. We're going to have coping issues with the patient and the family because of the hospitalization involved. And then we know if the heart's in dysfunction, we're at risk for cardiopulmonary failure, we're at risk for shock, we're at risk for bodily injury related to poor perfusion and poor oxygenation. And if we're having a backup of fluid overload, where does fluid like to go? It goes to the lungs, so we're at risk for infections. Also, if we're holding on to fluid and we're having a lot of fluid causing edema in our skin, then we're going to have our skin stretching, leading to potential thinner skin, leading to potential skin breakdown, which leads to a potential for infection. And we're also going to have risk for problems with mobility related to poor perfusion, poor oxygenation, and fatigue. So everything on this slide here is related to any type of cardiac defect, regardless of the defect. As long as we have an anatomic defect, these are all potential possibilities that can occur. So just to reiterate, if we have a patient who has a cardiac defect and their heart's in dysfunction and we're having poor perfusion and poor oxygenation, what are these patients going to look like? And if we know what they're going to look like, we know what we need to do in terms of assessment, and we know potentially what we need to do for intervention. So if I know my patient is having poor oxygenation and poor perfusion as a problem related to their cardiac defect and their cardiac dysfunction, then I know I need to be really on the ball with assessing things like my pulses, my skin, my level of consciousness, my vital signs, my work of breathing, because all of those things can be affected by my cardiac dysfunction. So I need to be trending my vital signs to make sure I'm not showing low O2 sats, make sure my heart rate's not increasing to show my heart's compensating, make sure I'm not showing signs of shock by having a decrease in blood pressure, make sure I'm not having changes in level of consciousness related to lack of oxygen and perfusion in the brain, and making sure my pulses are not showing me signs of impending shock. If I'm having poor cap refill and poor perfusion, then I'm going to have those weak and thready pulses. I also want to make sure that my heart is not compensating so much that my lungs are having to work as well, and I'm not having signs of increased work of breathing, or I'm not having my lungs having to work harder because I have so much excess fluid on the lungs. So I'm looking for signs of increased work of breathing and respiratory distress. So with all of that being said, if I see those things, what am I going to do about it? Okay? Eyes and nose come into play because of the fluid volume excess potential. I want to make sure that I am having a healthy kidney that's able to filter my waste, filter my fluid, and pull that fluid off effectively. If I do not have the proper oxygenation and perfusion, think about that in terms of full body. All of my organs are going to be affected. So that means I'm going to have poor perfusion to my kidneys. If my kidneys are not perfusing well, they're not going to work as efficiently either. And so that means we're going to have difficulty with pulling off waste, pulling off fluid. And so we're going to see changes in our output. So really, the heart is like one of the main organs, the main system that really feeds everything else, which is why it's so important that you understand this piece before we get into the really fine details of our cardiac defects. So again, regardless of defect, if we start to see signs of impaired gas exchange, signs of poor perfusion, signs of poor oxygenation, what do we need to do about it? So automatically what comes to your brain is, let's give them oxygen. And yes, if our patient is showing signs of poor oxygenation and poor perfusion, then we definitely want to give them oxygen. But with specific cardiac defects, we need to be careful with our use of oxygen. Remember that oxygen is a vasodilator. And if we're dilating certain areas of the heart, that could exacerbate our dysfunction. And I'll make it more understandable when we get into our defects. And if we're exacerbating our dysfunction, then we're just going to make the problem of poor perfusion and poor oxygenation even worse. So it's really important that you know the type of defect that you're working with before you just apply oxygen to help their poor oxygenation and poor perfusion. Sometimes the first step in caring for these types of patients is not going to be to give oxygen. Sometimes it's going to be repositioning. Sometimes it's going to be to give medications like diuretics to pull off fluid to help them oxygenate better. So it really depends on the defect, and we'll get into those specifics. Also, regardless of defect, we really want to try to cluster our care and decrease the patient's overall stress. If we cluster our care and try to decrease the stress of things like crying and agitation and excitability, where they're using more calories, using more energy, making their heart work harder essentially, if we're decreasing that, then that's going to help protect the heart. And we want to try to protect the heart and make it not work hard if we don't have to make it work hard. We also need to make sure that we're watching their activity levels. We want to try to make sure they're active and able to have the activity they need to practice developmental milestones so they can achieve those milestones, especially in our infants. But we also have to be protective of the amount of activity we're allowing, because the more activity, the more heart function you need, the more energy and strain on your heart, and the more calories you're going to be using. And patients with cardiac defects are already going to be using a lot of calories because their heart is already compensating and already working in overdrive. And so these patients are really high risk for nutrition issues related to that. So we really have to watch our activity. And we also have to watch for changes in activity. If a patient one day is able to do these certain activities and then now today they're not, that's a sign they're fatigued. And are they fatigued because they're not getting adequate calorie intake? Are they fatigued because their heart is working even harder and compensating even more, and they just don't have the energy because all that energy is being forced into their heart to work harder for their body to sustain life? So no matter what the defect is, we're always going to be at risk for infection with cardiac defects. We're at risk for infection because of the potential for that fluid volume overload, so we can have infections in our lungs very easily because fluid likes to live in the lungs when we have fluid volume excess. We also are at risk for infection because if we have fluid volume excess, we're going to have edema in our skin. That skin is going to become thinner. The thinner our skin, the more easily it's going to have breakdown. And then if we have skin breakdown, we're at risk for infection because our skin is open, and it's a very great segue for bacteria to get in and cause an infection. We're also at risk for infection because of the poor nutrition that our patients are going to be having, because they're not going to have the energy to eat. They're not going to want to eat. They're going to be so tired because their heart is working so hard to pump blood and pump oxygen to our body. And so without the proper nutrition and the proper protein, our body's ultimately at risk for infection in this way as well. So in terms of nursing care, we really have to be on point with looking and trending our temperatures and watching for any simple sign of infection. That could be fatigue, that could be activity intolerance, that could be temperature changes, that could be changes in our labs, that could be changes in our skin color, could be changes in discharge, that kind of thing. So we really have to be very cognizant of signs of infection in these types of patients. Our cardiac defect patients, as I've mentioned previously, are at risk for fluid volume excess. So how do we know a patient is retaining fluid? So we know that by seeing signs of peripheral edema, so edema in our feet and our ankles. We might have signs of weight gain in a short period of time. So these patients might need to have daily weights done so that we can trend their weights and make sure they're not gaining weight unexpectedly. Again, we might have extra heart sounds related to the extra fluid on their body and on their heart. We might have adventitious breath sounds. We might have lung infections starting to occur. And with fluid volume excess, we are at risk for skin integrity issues. And we're also at risk for potential acid-base imbalances. So we really have to, again, be very cognizant of our patient and watch for signs of fluid volume excess, because if our patient starts showing these signs, then we know for sure our patient is having a decline in their heart functioning ability, and we need to intervene very quickly. So that means maybe pulling off fluid, helping their heart out, maybe giving digoxin, so on and so forth. We know that our pediatric patients with congenital heart defects are going to have nutrition issues because they are working so hard to stay alive, that they're using more calories, more energy, and they are going to be so tired, they're not going to want to eat as much, and they're not going to eat as well as what we would expect them to. So in order to try to help them do better with eating the proper amount and to eat the proper nutrition that their body needs, there's a few things that we can do. And we're talking more about our infants, because remember, these are patients born with these defects, and we usually see that we need to intervene very quickly, or at least in the first year of life with these congenital heart defects, and not let them continue on for many, many years. Now, there's always exceptions to that, but usually we're going to be treating them and making sure that we fix the defect very early on in life. So for nutrition, we really have to make sure that they're getting the right amount of calories. So a lot of times, if the mom wants to breastfeed, we will encourage breastfeeding, but we will probably supplement that feed with formula, and the formula will most likely be high-calorie formula. And we do high-calorie formula as a supplement to breastfeeding, so that way the baby is getting the passive immunity from the breast milk and getting all the good qualities of breast milk, but also getting the right amount of calories, because the breast and the mom's body do not know that the patient has a congenital heart defect and is needing more calories. If the mom doesn't breastfeed, that's okay too. We'll just give high-calorie formula for all the feedings. When we do feed, we need to make sure that we feed no more than 30 minutes at a time, because if they feed for longer than 30 minutes, then they're probably expending more calories by sucking and swallowing than just actually getting the calories they need. So we don't want to make them over-expend the calories just for making them have a longer time they feed and finish the bottle. So with that, when we're feeding them, we always try to feed them with a soft, premature baby nipple, because that nipple is easier to suckle and easier to get milk to flow, compared to the regular nipple that you usually get on a bottle. And we want them to use as little effort as possible, so they're using as little calories as possible. We also offer the bottle feedings more frequently and in smaller sessions. So if they're solely bottle fed, depending on the age of the child, they can take up to 4, 5, 6 ounces if they're drinking formula. So for these babies, they might go, 4 hours before they need a feeding. But for these babies, we probably would give them 2 or 3 ounces and then feed them again in 2 or 3 hours. So the frequency is a lot more compared to your normal healthy baby with a normal healthy heart. We also would make sure that we would hold feedings for any baby that's breathing very quickly. So any respiratory rate above 50 to 60 breaths a minute, we would hold that feeding. And that's for safety, to help prevent risk for aspiration. Remember, if we're breathing really fast, like we're not going to be able to drink safely and swallow safely without potentially aspirating. So those are all considerations to make sure we understand in terms of nursing interventions for these types of patients. Another key piece to this whole congenital heart defect puzzle when caring for your patients and their families, we really have to make sure that as nurses we are providing a lot of good education and a lot of good health promotion to our families and our patients if they're able to developmentally understand. But a lot of times, like I said, we're dealing with infants, so we're going to be educating our family members. And so when a family has a baby who they thought was going to be super healthy and they were going to be able to take this baby home and love this baby, now they are stuck in the hospital. They are unsure of the baby's health. They don't know what's going to happen. And so it really changes their mentality. And so you really start to see family dynamics start to show more with these times of stress, which we have to make sure that we watch for if it's negative dynamics. And we also have to make sure that we really sit down and educate the family about what could happen, what we hope to happen, what our goals are, why we're doing what we're doing, and how can we involve the family into the baby's care. Because if we don't involve the family into the baby's care, they're never going to form that bond that they need to form when the baby is newborn and in that trust versus mistrust stage. So in terms of health promotion, if a baby is being able to be discharged from the hospital and being able to be cared for by their family at home, we really have to make sure parents are aware of signs of respiratory distress, signs of cardiac dysfunction to where it would need to be seen by a provider, how to take daily weights, which would help us understand like fluid volume excess, which would indicate, whether the dysfunction is worsening. Also, reviewing growth charts with the parents, reviewing milestones with the parents to make sure they understand what milestones we expect, how to get to those milestones, how to help their babies practice those milestones, but then also reassuring them that these babies might not be able to do things like tummy time, where they lay on their tummy and practice holding up their head. They might not be able to practice rolling over and scooting around and potentially crawling, depending on the age, because they're so tired because their body is working in overdrive. So we have to make sure we educate parents that that's okay, that's expected for these types of patients. And once we correct the problem, then they'll get more energy, they'll be able to eat better, they'll get nutrition back, and then they'll be able to achieve those milestones. It just might not be on the same timeline as what we normally would expect. We also want to make sure that we're connecting our families with community resources, social work, pastoral consult if needed, and community resources like support groups and other resources like medical equipment they might need for their home, education classes that they can go to understand how to do things like a tube feeding, because we might have to do a tube feeding at night to give the baby the supplement that they didn't get throughout the day. So make sure that they're just comfortable with those different types of nursing care pieces that the family might be giving that patient at home. Our congenital heart defect patients and their most likely dysfunctioning heart, we really need to be able to see what's going on in the body, and we need to be able to see how this heart is working and how it's affecting the rest of our body. So with our diagnostics and labs, we're going to be getting these pretty regularly with these patients. For labs, things like albumin and prealbumin are going to give us really good insight into their nutrition status, so we can try to work with the nutritionist and the provider to titrate their nutrition appropriately. Maybe they need to get more calories, maybe they need to get certain types of tube feedings to help make sure they're achieving their calorie and protein needs. We also might get a CBC to check for signs of infection and to check their hemoglobin and hematocrit to make sure that they are still able to produce from their kidneys the erythropoietin to then stimulate the bone marrow to create red blood cells. And remember, if the kidneys are not perfusing correctly, they're not going to work correctly, which means they might not be secreting that erythropoietin hormone correctly. So we're high risk for anemia in these patients as well. We also might be getting a BMP to look at electrolyte panel to make sure that our electrolytes are stable, because again, if the kidneys are not working, we're holding on to lots of waste, so we're at risk for things like hyperkalemia, hypernatremia, which makes us at risk for other things like electrical dysfunction of the heart and potentially seizures. We also would get a BNP, which is brain natriuretic peptide, which is a lab that tells us how hard the heart is working in terms of working against fluid. So the higher the BNP level, the worse that they have fluid on their heart, or the worse their congestive heart failure is. Some diagnostics that we typically get with these patients, definitely an EKG. Now again, we're talking about anatomic dysfunction or anatomic defect problems. So an EKG probably isn't going to give us that much information. It's just going to give us a baseline. And we can check this EKG over time to make sure they're not having electrical changes, maybe from like electrolytes imbalancing. We also might do an echocardiogram, and that's the ultrasound of the heart, and that's going to be a really good diagnostic for us for these anatomic defect patients, because we're able to see the structures of the heart and how blood is flowing through the heart. We also might do a chest x-ray if we're looking at the size of the heart to make sure we don't have things like cardiomegaly, and to make sure that we don't have fluid on the lungs. We also might do a cardiac catheterization if we know that a patient has a defect, because the cardiac cath is going to be able to show us even more specifically the structures of the heart compared to the echocardiogram. Now, remember that a cardiac cath, we would access the heart through the femoral artery or through the radial artery. A lot of times we're going to go through the femoral artery, and we're going to basically push the catheter up into the inferior and superior vena cava and go down to the right atrium and work our way through the heart. So there's a high risk potential with this procedure for damage to vessels and internal bleeding. But also we can use contrast with our cardiac catheterization, so we have to worry about, pre-procedure getting our consent, checking for iodine and shellfish allergy, and then post-procedure making sure that we are flushing those kidneys with fluid to make sure that we're not holding on to that contrast. Also, post-cardiac cath, there's always the risk for bleeding because we've accessed an artery. So once the catheterization is done, there is usually a pressure dressing that's holding basically pressure on that access site. And if that pressure dressing is saturated, that means that there's bleeding happening, and that's a major problem. We do not want that dressing saturated with blood, because that means the artery is still bleeding, and we know that that can lead to hypovolemic shock very quickly. So we would let the provider know right away. If we see a little bit of blood and it's not saturated, we might just reinforce that dressing with another dressing to make sure that we're really tying off that artery so it's not continuing to bleed. And we would trend our vital signs very closely to make sure we're not showing signs of shock, showing signs of increased heart rate and decreased blood pressure. Why do we have patients that end up with congenital heart defects? So like I mentioned in one of our earlier slides about the genetic component, there's a lot of genetics that can play into the reason why a child might be born with a congenital heart defect. So if a child has a genetic abnormality like Down syndrome, Turner syndrome, other types of syndromes, they are more likely to have a congenital heart defect. But there's other risk factors that can play into the risk for a patient being born with a congenital heart defect. So things like family history can play a big part, and that's related to genetics as well. If a patient has a first-degree relative who has a congenital heart defect, which is a genetic component, so that means mom, dad, sibling, grandmother, grandfather, if they have a congenital heart defect, then the patient's more likely to have a congenital heart defect. If there's a family history of someone in the family having an early unexplained death, or a baby dying early on related to SIDS or sudden infant death syndrome, then we can have, again, that genetic component that could lead to a patient developing and having congenital heart defect. Now, a lot of times with SIDS, we don't really know what causes SIDS, but especially, even a decade ago, SIDS we still don't know a lot about SIDS, but even a decade ago, we didn't know a whole lot about SIDS. And so, there's not autopsies done on every baby that has died from SIDS. And so there's a lot of times that we could have an undiagnosed defect in our babies who are born with SIDS, or born and then die from SIDS. Other risk factors can be related to the maternal health. So the mom's health while the baby is in utero can affect the baby having a potential risk for developing a congenital heart defect. So if the mom exposes the fetus to alcohol or illicit drugs like cocaine, heroin, or smokes a lot of tobacco, that can increase the risk for the baby to have a congenital heart defect. Also, if the mom gets a rubella vaccine or is infected with rubella when she is pregnant, that is an increased risk for the patient to have a congenital heart defect. So if you think about that, and you think about the MMR, and think about the vaccine schedule, we have to really be cautious when we're giving vaccines to our adolescents, because we could potentially, if they are sexually active and potentially pregnant and not know it, we could be exposing that fetus to something that could then lead to a major problem and lead to a major change in that adolescent's life, not only because of the pregnancy, but then because of additional stressors on top of that. So that's why we always do pregnancy tests in our adolescents before they get any kind of vaccine or certain medications or certain procedures done. Also, medications like Dilantin, which is a seizure medication, Accutane, so an acne medicine, thinking about our adolescent again, and our ACE inhibitors, which is a blood pressure medication. Those medications can also lead to the patient being more at risk for developing a congenital heart defect if exposed while in utero. So if we have mothers who are pregnant and they're on things like Dilantin and ACE inhibitors, we really have to think if there's another medication that might help manage their blood pressure, manage their seizure activity. And then if there's not, then weigh the risk versus benefit. Is the risk going to be outweighing the benefit or vice versa? So is it better for the mom to be on Dilantin and hope and pray that we don't get a congenital heart defect and have the mom not have a seizure while she's pregnant? Because if she had a seizure while she was pregnant, that could lead to the patient being born with something like cerebral palsy because of lack of perfusion to that baby through the umbilical cord if the mom were to have a seizure. So it's a really big kind of fine line there. But these are the major risk factors that are involved for babies born with congenital heart defects. So I know you guys are all anxiously awaiting our congenital heart defect categories and discussion, but one last piece of information I want to make sure you guys get is this discussion on decompensation episodes. So when you think about decompensation in general, that means your patient is declining. And so in a patient with a congenital heart defect, we know their heart is in dysfunction. We know their heart is not working like it should. So in moments where the heart is already not functioning like it should, we can have what we call acute decompensation episodes, which means the heart basically gets super tired all of a sudden and kind of just gives up. And when we have that moment of giving up, we might not end up in a code situation, but we end up in a decompensation situation. So that means the patient declines very rapidly, and depending on the defect, depends on what we need to do to help them not decline and get back to a baseline of their normal dysfunction. So our decompensation episodes can look very differently based on the type of defect. So as we go through the types of defects, I will make sure I highlight what we are looking for when a patient is decompensating for that specific defect and what we need to do about it for that specific defect. Okay, the moment of truth, here is our congenital heart defects. So our congenital heart defects are broken up into categories. So we have our increased pulmonary blood flow category, our decreased pulmonary blood flow category, our ductal dependent defects, and our obstructive defects. Now within each category you will see some bulleted points, and each bullet point represents a type of defect. So there are 4 main types of defects that are grouped in this increased pulmonary blood flow category. There's 2 defects in the decreased, there's 2 in the ductal dependent, and there's 2 in the obstructive. Now I'm going to talk about all of these that are listed, but the ones in red are the most important and the ones I want you to focus your efforts on the most. Okay, so that means like ventricular septal defect, patent ductus arteriosus, tetralogy of Fallot, transposition of the great vessels, and coarctation of the aorta. Our first category is defects of increased pulmonary blood flow, and our 4 defects are listed below. And again, the category and the defects are named really nicely to help us understand what's going on and where we're affected. It's not like our drugs who are named these crazy long names. Our category name and the type of defect really clue us into the problem. So if we're talking about a defect of increased pulmonary blood flow and we're talking about the heart, that means there's a problem in the flow of blood that's causing more blood to get to the lungs, which sounds like, okay, that's a good thing because that means they're getting good perfusion, good oxygenation if we're getting a lot of blood flow to the lungs. But if we're getting too much blood, too much oxygen, too much blood or fluid into the lungs to where our lungs can't handle it, that's going to be a problem, and that's going to lead to fluid overload in the lungs. So if you think about this, think about what this patient's going to look like. If we have too much fluid, too much blood going to the lungs, what is our patient going to be like? Our patient is going to be working harder to breathe. They're going to have good oxygenation, so they're not going to be blue because they don't have good oxygen. They're going to be nice and pink, but they're going to be working so hard to work through all that fluid. So they're going to have increased work of breathing, maybe even respiratory distress symptoms. They are going to have increased respiratory rate, increased heart rate. They might have adventitious breath sounds, and we'll get into those symptoms in the next slide. So with increased pulmonary blood flow category, there is an abnormal connection between the left side and the right side of the heart that's allowing a lot more of oxygenated blood to flow back into the lungs. So blood is moving just like fluid moves from left, which is high pressure, to the right side of the heart, which is low pressure. So we expect this to happen with this type of defect. And because there is so much more blood flowing back into the lungs, this causes way more work on the lungs, way more fluid on the lungs, leading to overcirculation of the pulmonary system, increasing resistance, and increasing the pressure in the lungs, leading to pulmonary hypertension. Here are the 4 types of defects listed. So we've got ASD, or atrial septal defect, VSD, which is ventricular septal defect, AV canal, and which is arteriovenous canal, which is an ASD and VSD together. And then we have PDA, which is patent ductus arteriosus. So this slide does a good job of kind of breaking down the defects, but I'm going to draw the defects here in a second. So before I draw the defects, I just want to show you these little pictures. So these pictures are of the defects that were highlighted red that you're responsible for. So the first is ventricular septal defect, which is this left-hand column here. And then we've got the PDA, which is over on the right-hand side. So if we think about where's the septum in the heart, the septum in the heart is the area that divides the right and left sides of the heart. So it's this little area here. And in a normal heart, there would be this nice connection here, okay? But because we're dealing with a ventricular septal defect, you think about ventricular, so it's not in the atrium, it's in the ventricles, and there's a septum defect. That means there's a hole in the septum at the ventricular space. So like we mentioned in the first couple of slides of this whole lecture, we know that fluid moves from high pressure to low pressure. And remember, the highest pressure chamber in the heart is the left ventricle. So blood, if there's an abnormal connection, blood is going to move from high pressure to low pressure. Okay? And when blood is in this left ventricle, this high pressure chamber, and there's this abnormal connection, it's automatically going to flow to the lower pressure area, which is the right ventricle. Now, if you remember back to our normal flow of blood, how does blood normally flow? Well, blood normally flows through the vena cava into the right atrium, down into the right ventricle, into the lungs. So all this extra fluid coming from the left ventricle is going back into the right ventricle and circulating back into the lungs, which is why it's in this category of increased pulmonary blood flow. All right, let's erase this. And let's look at our PDA. I wonder if I can. I might have to turn my face off. Let's see. There we go. Okay, so now we're talking about PDA. Now, PDA, patent ductus arteriosus. So patent means open. Remember, the ductus arteriosus is that little structure that was in place while we were in utero, and after we breathed our first breath of air, it should have changed into a ligament. But because it didn't change into a ligament, it's still open, hence the name, patent ductus arteriosus, okay? So again, the names are really helpful for us. So if you recall, the ductus arteriosus connects the aorta to the pulmonary vessel. And so what happens is we have this high pressure vessel and we have this lower pressure vessel. So when we have this connection between the two, blood is going to move down from the aorta back into the lungs, okay? Which is again why it is in this increased pulmonary blood flow category. Now, we don't have pictures of ASD, which is atrial septal defect, or the AV canal. So I'm going to just show you on these pictures. Actually, I'm going to draw it. Let's see. And this is how I would normally draw it in class, because this is how you would probably draw it on your paper. So I have my beautiful heart here, and I'm creating my septum and my chambers. So this is the right side, and this is the left side. Now, if I have the VSD, again, there's going to be a little hole right here. Oh, it took away my whole line. So there's going to be a little hole right here with my VSD, okay? Now, if I had ASD, which is atrial septal defect, I would have a hole. Remember, atria, septal, so I'm going to have a hole in the septum at the atria. So I'm going to have a hole right here in my atria. And remember, the left side of the heart is higher pressure, so there's blood moving from the left atria back into the right atrium, and that normal flow of blood occurs. So remember, blood goes vena cava, right atrium, right ventricle. And so this blood that's pulling back into the right atrium is going to hang out down at the right ventricle and go up into the lungs. So that's ASD. And then AV canal is basically a VSD, which we have here, and an ASD, which is what I just drew. It's just both together. So again, thinking about what increased pulmonary blood flow, all this increased fluid and this increased oxygen to our lungs, what does that patient look like? So it's going to be a really hard job for the lungs to handle all that fluid. So we're going to have lots of fluid on the lungs. We're going to have a result of increased work of breathing, crackles, adventitious breath sounds. It's going to perpetuate our lung infections, and we're going to have signs of heart failure. Now, there's two types of heart failure. There's left-sided heart failure, and there's right-sided heart failure. If you think about left-sided heart failure, if you think about the heart, we've got this heart here. If we have fluid backing up into the lungs, that's going to be a problem with the left side of the heart. If we have fluid backing up into the legs, that's going to be a problem with the right side of the heart. So if you think about this problem, they're probably going to have left-sided heart failure, which means they're going to have lung effects, which is what we're talking about here. Our increased work of breathing, our crackles, our pulmonary infections. Now, with all of our defect patients, no matter what category, no matter what defect, they're always going to have these symptoms. So they're always going to have some symptom of heart failure, whether that's left-sided heart failure or right-sided heart failure. In this case, we're having left-sided heart failure, which is why we have the pulmonary problem. We're always going to have a murmur because there's a defect abnormality. There's a risk for pulmonary hypertension, which that's the caveat. That's the only thing that's not for every defect. But for every defect, we're going to have a murmur, we're going to have poor feeding, and we're going to have slow growth, okay? And that should be understandable based on our foundation knowledge we built on before we got to this part. Since their lungs are getting lots of good oxygen, they are acyanotic at rest. They should not be cyanotic because they're getting plenty of oxygen. So for these patients, these special patients, we have to make sure that when they are showing signs of decline, we are really cautious with the amount of oxygen we're giving them. So again, oxygen is a vasodilator. So if we think about our heart and we're thinking about how much blood is moving back into the lungs, and if we vasodilate everything, which means all of our vessels, including our lung vessels, when we vasodilate, that improves perfusion, it improves the flow of blood. Do we want to improve the flow of blood to our lungs? No. If we give high amounts of oxygen, it's just going to exacerbate our problem. So we really have to be very judicious with the amount of oxygen we give these patients. So for these patients, our ultimate goal is going to be to pull fluid off to help them oxygenate better, breathe better, and not make their lungs work so hard. So we're going to give diuretics. We're going to do position changes like semi-Fowlers, high Fowlers. We also might do position changes to help change the flow of blood. So in times of acute decline, if we put their knees to chest, so in a fetal position, that knees to chest causes a pressure change in the thoracic cavity and changes the flow of blood back to a kind of normal sequence in that acute moment. Now, is that fixing the defect problem? No. But in that acute decline, we want to try to help the heart out as much as we can. So ultimately, these patients, for the most part, are going to have surgery to repair their defect. Now, there are times when a patient might have a really, really tiny VSD, or really tiny hole in the septum, and we might not repair that. We might just leave it if they're not having any major effects. But it really depends on the patient. Most of the time, they have to have surgery. If we don't have surgery, they're going to end up with pulmonary hypertension, and then they're going to have lifelong effects from that, which we're not going to get into. So in terms of medication, like I said, we'll give diuretics to help pull off fluid. But for the patent ductus arteriosus specifically, if we catch that the patient has an open ductus arteriosus directly after birth, and we realize on an echocardiogram that their ductus arteriosus did not close, if we're within the first couple of days, like 24 to 72 hours of life, and we know that ductus arteriosus has not closed yet, we can give a medication called indomethacin that will help force our hand, basically, force that defect to close and turn into a ligament. So if we catch it early, we can do indomethacin just for PDA. Now that's not going to fix our VSD and our ASD and our AV canal. So remember, when you're looking at these, try to think through the defect and the patho behind it, and try to just know exactly what I've said here. Don't go and research all these things. Don't go and write pages and pages of notes, because what I'm giving you is what you need to know. Now we're going to talk about our defects of decreased pulmonary blood flow category, and this includes tricuspid atresia and tetralogy of Fallot. And if you think about this category's name, decreased pulmonary blood flow, that means there's not a lot of blood flow getting to the lungs. So what is my patient going to look like? They're going to be not oxygenating well, and they are going to be working harder to breathe because they're trying to oxygenate. They're probably not going to have adventitious breath sounds because they don't have a ton of fluid backing up into the lungs. So this is kind of the characteristic of decreased pulmonary blood flow defects. With decreased pulmonary blood flow defects, these defects obstruct the flow of blood to the lungs for different reasons. And because there is an abnormal flow of blood to the lungs, there's poor perfusion to the lungs, this leaves the kidneys trying to compensate, because the kidneys are like, oh, you're not getting enough oxygen, so let me make some more red blood cells so that we can get more oxygen to your lungs. But in reality, your body doesn't realize that there's a problem with the heart. Your kidneys do not realize that no matter how many red blood cells you make, if you don't fix the defect, it's not going to fix that pathway of blood flow to the lungs. So that in itself is the major problem with this category, is there's an anatomical issue that's not allowing blood to flow from the right side of the heart into the lungs. So our two categories here are tricuspid atresia and tetralogy of Fallot, and you're really just responsible for tetralogy of Fallot, but I am going to talk about tricuspid atresia a little bit. So atresia means no connection, and if you think about like esophageal atresia, that means that the esophagus is not connected to the stomach. So if you think about that in terms of tricuspid atresia, this means that the tricuspid valve is not serving as a connector. So if we have our heart, and the tricuspid valve is usually here between the right atrium and the right ventricle, normally what happens with tricuspid atresia is basically there's no valve. There's an abnormal layer of tissue, and so no blood or very little blood can get from the right atrium down into the right ventricle. So if you think about this, if not a lot of blood or no blood is getting to the right ventricle, that means there's not a lot of blood or no blood getting to the lungs, hence decreased pulmonary blood flow category. Also, if you think about this, the blood has to go somewhere. So yeah, the right atrium might be working really hard, so we might see that right atrium expand a little bit, but also that fluid and blood is going to be backing up into the body, which is right-sided heart failure. So if we're not getting a lot of perfusion to the lungs, not a lot of oxygen to the lungs, our entire body is affected. So our entire body is going to have not a lot of oxygen. So we're going to see that with cap refill. We're going to see that with our O2 sats. And if we have lots of blood backing up into our body, we're going to see that edema happen and our tissue integrity come into play. Now for tetralogy of Fallot, tetra means 4. So if you think about the actual name of the defect, there is 4 defects to make up tetralogy of Fallot. There's a VSD, which we talked about. There's pulmonary stenosis, there's an overriding aorta, and there's right ventricular hypertrophy. And I'm going to show you a picture here in a second. Here's a picture of a heart that is a tetralogy of Fallot heart. So first, we already know we have our ventricular septal defect. We already know what that means. So that means blood is moving from the left ventricle into the right ventricle, which is great because we want that blood to try to get to our lungs. But remember, we're in the decreased pulmonary blood flow section, so that means there's something not allowing all this blood that's getting to the right ventricle to go up into the lungs. So what happens in tetralogy of Fallot, we have this pulmonary stenosis. Remember that stenosis means narrowing or hardening. And so we have a narrowing of the pulmonary valve and the pulmonary artery. And so that narrowing, that smaller circumference of the vessel doesn't allow as much blood flow to get to the lungs. So that's our other problem. So we've got 2 problems. Then our other issue is that because so much blood is coming in from this ventricular septal defect, we also have this overriding aorta, which means the aorta is basically sitting where the septum should be. So the aorta is midline of the heart, so that means blood, this high pressure vessel is pushing blood into this hole. And remember, you've got blood pushing in from the left side, so automatically blood coming from the left side of the heart and blood coming from the aorta are all pushing into the right ventricle. So because of that, the right ventricle gets overloaded with fluid and starts to work harder, which we know the heart is a muscle, and as it works harder, it gets bigger. And so we have right ventricular hypertrophy. So those all make up what we call tetralogy of Fallot. As I mentioned earlier, with our category of decreased pulmonary blood flow, we're going to have systemic cyanosis because our lungs are not getting oxygen. Okay? No matter what the defect, we're not getting oxygen, so we're going to be cyanotic. No matter what the defect, we're always going to have a murmur, we're always going to have poor feeding, we're always going to have fatigue, not achieving developmental milestones, etc. For these patients specifically, in this type of category, we're going to see a lot of oxygenation symptoms. So clubbing, maybe even like a barrel-shaped chest, and because our lungs are not getting oxygen, they're going to compensate. So we're going to see increased work of breathing, increased respiratory rate, increased heart rate. We may see in our tetralogy of Fallot patients specifically, maybe some pulmonary infections related to the aorta being overriding and more fluid backing up into the lungs from the left side of the heart. But we're also going to see that peripheral edema in both defects because this category is really focused on that right side of heart failure. For tricuspid atresia, we have to do surgery in order to create a connection between the right atrium and the left atrium. So for these patients, we realize they have tricuspid atresia pretty early on after birth, and we can confirm it just by what they look like because they're probably going to be super blue when they come out of the womb. So if we know that they're super blue when they come out, we're going to try to give prostaglandin E right away. Prostaglandin E is a medication that keeps the ductus arteriosus open. And if we think about this, we have this heart that doesn't allow blood to flow from the right atrium to the right ventricle, but we have this aorta that in utero has this connection between the aorta and the lungs, and these are my little crude lungs. And so we want to keep this connection between the aorta and the lungs because we know that blood moves from high to low, and we know the aorta is a super high pressure vessel. And so by keeping that connection, that aorta is going to feed blood into the lungs, and we're going to maintain life because the lungs are still getting oxygen and blood flow. If we don't do that, this patient could die if we don't do surgery right away because they're not getting any flow of blood or any oxygen to their lungs. Now, for tetralogy of Fallot, we're going to do surgery within the first year. They're able to survive without surgery right away because they're still getting flow of blood to the lungs. It's just more of a functional obstruction problem. Now, these patients, we want to give, if they're having acute decompensation episodes, so if they're declining very acutely, our goal is going to give high concentrations of oxygen because we want to vasodilate those pulmonary vessels to try to receive as much blood as they can from that right ventricle. So we're going to maximize that side effect of oxygen by giving high concentrations of oxygen when they're in a decline episode. In addition to that, we can also do reshunting, so that means knees to chest to try to change our thoracic pressure to try to shift our flow of blood back to normal and try to help that blood go into the left side of the heart and out into the body instead of trying to reshunt back into the right ventricle. But ultimately, they're going to have surgery to repair all 4 defects as well. Our third category is obstructive defects. Now, these are a little bit more difficult to understand in terms of just the name of the category. And within this category, we have aortic stenosis and coarctation of the aorta. Obstructive defects, we have an anatomic narrowing of specific vessels within the heart, specifically those vessels that leave the heart. And if you think about the vessels that leave the heart, that's your aorta and the 3 and the 2 vessels on the side as part of that aortic anatomy. So those vessels are narrowed in certain places, and so we're not able to push blood out into certain parts of the body like we normally would. And because that's happening, there's blood backing up into the left side of the heart, which then backs up into the lungs, which is called left-sided heart failure. And then over time, as the lungs get filled up with blood and fluid, eventually that fluid will then back up into the right side of the heart. So you can have both left and right sided heart failure with obstructive defects, but it starts at the left and then moves to the right. So here is listed the coarctation of the aorta and the aortic stenosis information, and I'm going to show you pictures or draw you pictures of both to make it a little bit more understandable. This picture specifically shows you a picture of a heart with coarctation of the aorta, which is the defect that you are most responsible for. But I will tell you about aortic stenosis as well. But let's focus on coarctation, or coarc, as we usually call it, first. So with coarc, we usually have a narrowing at the aortic arch. So you can see in the picture that there's this narrowing occurring right here as it arches. And so because of that narrowing, we have decreased perfusion of blood going out of part of the aorta, but we still have normal perfusion going through some of the aorta. So if you remember back to one of the first slides, remember that the top three little branches of the aorta feed the top of the body, so the chest and the head, the head and the brain, whereas the bottom parts of the aorta feed the bottom part of the body. So if you think about what a patient with coarctation might look like, if they're getting really good perfusion up top, they're going to be nice and pink, have good pulses, maybe even bounding pulses, because the pressure up here is going to be higher compared to the pressure down here, which is lower. Because if you think about this narrowing is kind of a roadblock. And if we have a roadblock or an obstruction in place, everything behind that obstruction is going to be building, and we know with building pressure, it's going to increase our pressure. So somebody with coarc might have really high pressure in their upper extremities, like high blood pressure. They might have bounding pulses. They might be really pink. They might have really good O2 stats. Their vital signs in terms of their heart rate might be elevated. Their respiratory rate might be elevated, and their blood pressure might be elevated. And remember, back to our first slides, what do we expect our blood pressure and our pulses to look like in a normal pediatric patient? We expect our pulses and our blood pressure to be pretty similar, upper and lower, because of the smaller body size of the child. Now, if we're talking about this functional obstruction where there's lower pressure forcing blood down to the lower part of the aorta, and there's less perfusion overall to that area of the aorta, that means there's less perfusion and less pressure pushing blood and oxygen to our lower part of our body. So probably this patient is going to, in their lower body, have lower blood pressure, poor, weak pulses, maybe even some paleness, some coolness to their skin. So a patient with coarctation is going to have high blood pressure and bounding pulses in their arms, with weak femoral pulses, cool lower extremities with low blood pressure in their lower extremities. They can also have dizziness and fainting. And this is because their brain and their cerebral tissue is getting overperfused with this high pressure of blood pushing through those vessels. And those vessels are quite small in the brain. And so they're getting overperfused, overoxygenated. And so the body responds by getting dizzy and fainting. We call these death spells when they have decompensation episodes. And I forgot to mention in the last, when we were talking about tetralogy of Fallot, when they have an acute decompensation episode, theirs are called TET spells, T-E-T, TET spells. So you've got TET spells and you've got death spells. I don't know why they get their own special name, but they do. And again, the spell is just the decompensation moment. So we've went over coarctation of the aorta. So let's go over quickly aortic stenosis. So we've got our heart. Oh, that's a really big heart. Let's try again. we've got our heart, and we've got our little aorta, branching off, and I'm sorry for my lovely drawings. So in coarc, we have the narrowing down here. So all of our uppers are still getting nicely perfused. But with aortic stenosis, we have the narrowing more here. And so that means that there's less perfusion to the upper and less perfusion to the lower. So the entire body is going to be a poor perfusion and poor oxygenation state. So overall, with these type of defects, we're going to see activity intolerance, we're going to see increased respiratory rate and heart rate because of the overworking of the heart to try to pump out the blood from the left side of the heart to the aorta and out to the body. And then like with every defect, no matter what the defect, having the activity intolerance, the murmur, the slow growth, the poor feeding, that's expected. Now these patients are going to be pale or cyanotic at rest, again, because they're not getting good perfusion to parts of their body. Now when a patient has coarctation and they're having a death spell, so that acute decline moment, you're going to see a rapid color change. So you're going to see them go from nice and pink to completely blue. They might have some dizziness, they might have some fainting. The top interventions we're going to do is oxygen and reshunt back into that fetal position. We can also try diuretics, but especially if they're in left-sided heart failure, but that's not going to be our number one. And then ultimately, in order to fix this defect, they have to go to surgery. Our last category of congenital heart defects is our mixed defects. And again, this category is a little bit harder to interpret just based on the name. And this category includes the transposition of the great arteries and hypoplastic left heart. So in our mixed heart defects, we are having it called mixed because the survival of the patient is dependent on the ability to mix our deoxygenated and our oxygenated blood. And if you think about this, our deoxygenated blood does mix with our oxygenated blood in a normal flow of blood through the heart when we exchange that blood flow in the lungs with exchange of oxygen. So when you read that, the mixed defects, as part of the characteristic thing with mixed defects, is that there is no mixing of deoxygenated and oxygenated blood. So mixed defects are very severe and cause really severe outcomes for our patients and can cause death very easily. So the two defects, transposition of the great vessels and hypoplastic left heart. With hypoplastic left heart, we have, if you look at the name hypo, that means under, and plastic means developed, and those are Latin stems. So underdeveloped left heart. So that means that the left side of the heart, that means the left ventricle specifically, is very, very small. And remember, the left ventricle is supposed to be the biggest, strongest chamber in our heart. So if it's now the smallest and weakest chamber of our heart, it means it's going to have a really hard time pushing blood up into the aorta and out through our body. So there's a really high chance that we're going to have blood backing up into our lungs. So these patients are going to be less severe looking compared to something like transposition of the great vessels, but over time, they're going to potentially have a greater risk for death because if you're not getting any kind of adequate perfusion from the aorta out into the body, your tissues of your body are not getting oxygen and blood perfusion, and that can affect your body over time. It can affect your body greatly and cause you to have such low oxygen in your tissues and have such low perfusion that your tissues basically start to die. With transposition of the great vessels, trans means change, and so we usually refer to this as TOV or TOV or transposition of the great vessels. So there's lots of different names. But what happens is In transmission of the great vessels, if you think about the great vessels are our aorta and our pulmonary artery. So normally, our aorta is connected to the left ventricle, and our pulmonary artery is connected to our right ventricle. But in transmission of the great vessels, they have flipped. And so now the pulmonary artery is connected to the left ventricle, and the aorta is connected to the right ventricle. And I'm going to show you a picture. So if you look at the right hand picture, this is a picture of transposition of the great vessels. So you can see the aorta is connected to the right ventricle, okay? So blood is coming up through the right side of the heart, coming in from the body, going up into what's supposed to be the lungs, but instead is going into the aorta and going out into the body. So these patients are blue because they are not getting any oxygen at all. So it's really, really easy to diagnose directly after the baby is born. And then you can see the pulmonary artery is connected to the left side of the heart. And that's not normal. So the left side of the heart and the pulmonary artery and the pulmonary system are getting nice and oxygenated, but the rest of the body is not. So again, these patients, it's really easy to pick up this disorder, and so it's really easy to intervene very quickly. Now with hypoplastic left heart, the picture to the left, you can see how small the left ventricle is. And like I mentioned earlier, because that left ventricle is not able to pump really good amounts of blood to the aorta and pump that out through the body, over time, that body is going to be wanting that blood and wanting that oxygen. And so hypoplastic left heart is actually really hard to pick up on because when the baby is born, they're not going to be blue. They're going to be normal looking. But over time, they're going to show signs of fatigue, poor weight gain, poor feeding, failure to thrive potentially. And so over time, you see this patient and then you might say, oh, maybe they have hypoplastic left heart based on all their symptoms. But by that time, it might be too late for the tissues to go back to normal because they've suffered so much in terms of not having the oxygen and perfusion they need. The common symptoms that we see with transposition of the great vessels is, again, a very blue patient. So cyanotic is our key indicator there once they're born. So as soon as the patient is born and they come out blue and we cannot get them to turn pink, they go straight in and get administration of the prostaglandin E. And that's, again, to keep the ductus arteriosus open. So normally the ductus arteriosus would close right after birth, but in the case of the transposition of the great vessels, we really want to keep the ductus arteriosus open. And if we keep the ductus arteriosus open, now remember, the aorta is now connected to the right ventricle. And the pulmonary artery is connected to the left ventricle. And so if I keep the ductus arteriosus open, which, remember, the ductus arteriosus connects the aorta and the pulmonary system. So if I open that connection, then blood can mix together and help oxygenate the patient. So transposition of the great vessel patients can actually survive if we give them this prostaglandin E, and then they will have to go to surgery. And what happens in surgery is basically the surgeon just flip-flops the two great vessels back to where they should be. Now, it's very simplified, obviously, to what surgery is like, but that's essentially what happens, is they put the aorta back connected to the left ventricle, and they connect the pulmonary artery back to the right ventricle. So it's very easy to make a transposition of the great vessel patient survive. Now, with hypoplastic left heart, you're going to see cyanosis get worse over time. Eventually, like at first, they're going to be pale, but then eventually they're going to be become more cyanotic. They're going to have a lot of activity intolerance, and then, of course, because we're talking about a heart defect, both are going to have things like murmur, things like poor feeding, things like poor growth and development, etc. Now, for hypoplastic left heart, we really want to try to think about giving the patient inotropic medications, so like digoxin. and we give them digoxin to help improve the contractility of that heart muscle to help that left ventricle out. With hypoplastic left heart, we can also give prostaglandin E to keep the ductus arteriosus open to help with oxygenating the blood and oxygenating the body. And with hypoplastic left heart, they have to undergo multiple surgeries to basically build back that left ventricle. All right, so we're done talking about our specific fine details about our congenital heart defects. So now we're going to look at just an overview of some medications that we've talked about and some other medications that we may not have focused on yet. For our heart patients, we are going to use digoxin a lot to help with contractility. So remember, in the adult patient, we would hold dig if our heart rate is less than 60. Now for pediatric patients, we know that our heart rates are normally higher than the adult patient. So when we give dig, we want to hold digoxin typically if our baby's heart rates are less than 100. And when we're listening to our heart rates, we're going to listen at the apical pulse for a full 1 minute. So when you're looking at these medications, we also have ACE inhibitors that we use to help manage blood pressure. And we also use diuretics to help pull off that fluid. And remember, we talked about our diuretics before, our loop diuretics and our potassium-sparing diuretics. And obviously that is all based on our lab work and our kidney function. So what I would recommend is reviewing digoxin and reviewing dig toxicity. Otherwise, I think you guys will be fairly okay with, with these medications. Remind yourself with the dig toxicity, also remind yourself how potassium plays into that as well. Okay guys, so this ends this portion of the cardiac lecture. So if you want to let me know if you have any questions, just put them on the discussion board or email me. And for the second part of the cardiac slides, it will be in a separate recording. I hope you guys enjoyed this lecture. And again, let me know if you have any questions. Thanks.